All right, good morning. Thank you for the introduction. I'll start by explaining the rationale for our study. In the pediatric solid tumor world, metastatic or recurrent sarcoma and high-risk neuroblastoma continue to have very poor prognosis, so new therapeutic developments are obviously needed. So we went ahead and evaluated the anatomic site and surrounding structures of each tumor to determine the targetability by MR-HIFU. And the purpose of our study was to establish the number of pediatric sarcomas and neuroblastomas in a targetable anatomic location to help guide the design of initial clinical trials using MR-HIFU. Our study was a retrospective study. We looked at 121 patients with sarcoma and 61 patients with neuroblastoma, identified by our pediatric oncology tumor registry at Children's Health over a 5-year period. And those patients who had available cross-sectional imaging were included and analyzed. Tumors were classified based on their location and the surrounding structures within the ultrasound beam path as A, not targetable, B, completely or partially targetable with the currently available MR-HIFU system, which was the Philips Sonali V2 model that we used, and C, potentially targetable if respiratory motion compensation technique was used. And respiratory motion compensation techniques would be needed for those tumors located in areas affected by respiratory motion, such as the abdomen, because MR temperature mapping could be affected by motion. So we used our hospital radiology pictorial archival system and software to pretty much mimic the anticipated simple geometric ultrasound beam path, as you can see in the top left figure. And we use this beam path to pretty much analyze each tumor lesion on the radiologic study. And you can see on the top figure that's a targetable right tibia osteosarcoma because there is no critical structures between the ultrasound transducer and the center of the tumor, where the two lines meet, and then 4 centimeters beyond the center of the tumor, which was the safety margin, where considerable heating could still occur from the MR-HIFU. The bottom figure shows a not targetable thoracic spine Ewing sarcoma, and the criteria for a not targetable lesion would be if there was a highly absorbing or reflecting structure such as bowel, trachea, or bone within the ultrasound beam path that is, blocking the beam path, or within that safety margin where heating could still occur. And another criteria for a not targetable lesion would be if the ultrasound beam path fell within 1 centimeter of the spinal cord or the brain or the skin. So this figure summarizes kind of the main results of our study, and the color of the circle represents targetability, and the size of the circle represents the number of lesions. And as you can see, if you look at the sarcoma skeletal figure on the left side of the screen, you can see that if you look at the primary lesion, 77 out of 121 lesions were targetable with MR-HIFU, and that was about 64%. If you look at the metastatic and relapse lesions on the right side of the skeletal figure, you can see that about 15% were targetable, 42 out of 280 lesions. And you just look at the general color scheme, you can see a lot of green in the extremities and pelvis, and it seems to be that a lot of the extremity and pelvis lesions were targetable for both the primary and the metastatic and relapse lesions. And that big chunk of red that you see in the chest lesions for the metastatic and relapse sarcomas were because a lot of those arose from the lungs as metastatic and relapse lesions, so those were not targetable. If you look at the neuroblastoma figure, you can see that on the left you can see the primary lesions, and about 15 out of 61 lesions were targetable, so about 25%, and those were all located in the abdomen, making respiratory motion compensation technique needed in those lesions. And then a lot of the lesions on the metastatic and relapse side were located in the pelvis and extremities. About 80% of the relapse lesions that were targetable were located in the extremities and pelvis. So to conclude, I think our study provided kind of an anatomical survey for MR-HIFU targetability in pediatric solid tumors. And we found that most sarcoma tumors located in the extremities and pelvis are targetable, and about only a small percentage of metastatic and relapsed sarcoma tumors were targetable because of their nature to arise in the lung. And neuroblastoma was less commonly targetable because of the frequent intra-abdominal location and the proximity to the spine. So to summarize, finally, pediatric solid tumors are anatomically targetable with MR-HIFU, but obviously further studies are needed to overcome the obstacles in targeting the lesions in the clinical setting, including the depth to reach the target, the volume or the size of the target, and respiratory motion, which is always an issue with MR temperature mapping, just to name a few of those obstacles. So I would just like to thank you for everyone for listening and my team members. Thank you.
We have time for questions.
So I have one question. In the relapse setting for the targetable areas in the extremities, did you run into issues of targetability due to scar tissue or prosthesis for these patients?
That's a good question. Well, looking at, our study was mostly looking at the accessibility, so we didn't really take into account much of the, kind of the scarring or the prosthesis. And when we did have patients with those issues, they were pretty much not targetable. Yeah.
And Dr. Shim, I apologize.
It's
She's
okay.
from UT Southwestern in Texas, not Georgia.
I am a fellow at Emory right now, but yeah, I was at Children's Health. Yep.
This is a general question, not just for you, but for anybody who's treating things that haven't been approved. I understand that this was just a theoretical study of access, but what would you have to go through to actually do a treatment for something that's not already approved in children or anybody?
That's a good question. So I know there are some clinical trials. I think Dr. Kim could probably say more about it for pediatric solid tumors undergoing right now. And I know there are some studies done in China looking at some of the osteosarcoma targeting in children. So, I mean, it would start off, going through the phase trials, obviously, and trying to figure out what would be the safety issues.
Well, do you think that anybody could get through with just an IRB approval on something like this as an off-label use?
That's a good question. I don't know.
I think Dr. Buckner and I, for example, and others have used the technology off-label to treat soft tissue tumors, desmoid tumors, which are benign but locally very aggressive. Dr. Kim can talk about sarcomas, for example, and the approach they've taken.
So we have a clinical trial available for pediatric patients with relapsed solid tumors. We, for the Philips device, which is not labeled here in the U.S., we have submitted an IDE exemption through the FDA for compassionate use for a patient with desmoid tumor, which has been approved.
Yeah. Just a comment, Dr. Shim, as well. So from my experience, the approach you guys took in terms of the measurements are fairly conservative.
Right.
So I think the actual numbers may be even higher. We routinely treat within a centimeter of the skin, and 4 centimeters in the far field is a generous margin.
Right.
As you saw from Dr. Buckner's treatment of near the sciatic nerve, he got pretty close to that nerve, and it was completely spared.
Exactly.
So I think you guys were conservative in this. I think the actual numbers.
Yeah, and I
even
think
better.
we mentioned that too, that we're probably pretty conservative, and the actual numbers
Good to start
could be
that
higher.
way, I think, yeah.
All right, cool. All right, thank you.
Thank you.
Thank you.